We talked a lot about pancreatitis in the medicine videos, but I do want to review pancreatitis here, simple diagnosis and treatment, but then also focus on when surgery is appropriate in the setting of pancreatitis. And the answer is not that often. So, if you remember from medicine, someone with pancreatitis is going to come in with an epigastric abdominal pain. And that pain will bore through to the back. And it will be positional. That is, if you stretch the precordium, you stretch the pancreas, that hurts because it's inflamed. If you lean over, you relax the precordium, you don't stretch the pancreas, it doesn't hurt that much. And there may be some nausea and vomiting. Pain is worse with food. The problem with pancreatitis is that the digestive enzymes that are supposed to digest the food in the duodenum end up digesting the pancreas, which hurts a lot. So if you have this, you're going to then get the diagnostic test, which is a lipase. Yes, amylase is on the list of things to get, and especially if you can get the pancreatic specific amylase, but amylase has a lot of false positives. Vomiting alone, gallbladder disease, it's best to use the lipase, and what do you know? In this person, 3 times the upper limit of normal, they've got pancreatitis. And to treat regular old pancreatitis, not severe, not going to die pancreatitis, but regular pancreatitis is treated with NPO. So you stop the stimulus for the production of the pancreatic enzymes. And because you don't want them to get dehydrated, you give them intravenous fluids. And because it really hurts, you give them pain control. Generally, IV. And then when they're ready to eat, you let them eat. And you notice what's not up here. What's not up here is the CT scan. You can use the CT scan for the initial diagnosis of pancreatitis when the enzymes are negative and you are sure that this is pancreatitis. CT scan doesn't hurt people. CT scan doesn't help you. Don't get a CT scan for acute pancreatitis, especially if the enzymes are elevated. Don't need it. The right upper quadrant ultrasound and a triglyceride panel, good ideas. This is going to be the next day after you've already started the management of pancreatitis, looking for the etiologies, knowing that the most common etiologies are going to be alcohol, gallstones, and hypertriglyceridemia. Things like Trinidadian scorpions and black widows not going to cause pancreatitis in anyone you're going to see. Yes, there's a very long mnemonic you can memorize, but when you actually see patients, which you're going to care about, gallstones, alcohol, hypertriglyceridemia, medication side effects. So you'll notice also no surgery. So when does surgery play a role? Well, the CT scan may not be necessarily the worst thing in the world. You don't need it on day 1. But there might be times where you do. In the first few hours or days of the acute pancreatitis, if the person is getting sick as shit, they're looking bad, they're hypotensive, you need to find out why they're third spacing all their fluid. This you might want to get right away. As they get bad, you might get the CT scan. Still another complication of pancreatitis. A couple days later, that's 5 days to a week. Now remember, there's pancreatitis, itis, so there's a little bit of inflammation, a low-grade fever, and some leukocytosis is not a big deal. But if someone looks floridly septic, and they've got ongoing fevers, and a leukocytosis that won't go away, well, now you're thinking it might be an abscess, so it's worth getting the CT scan. Or you get it a couple of weeks out. They leave the hospital, they're on their way back in for their follow-up visit, and they have early satiety. Weight loss, and abdominal pain. You see, the CT scan becomes useful for the diagnosis of the complications of pancreatitis, but has very limited utility in pancreatitis itself. For this person who's getting sick as shit and hypotensive, what you're worried about is necrotizing pancreatitis. This person's going to do poorly. They're probably going to end up in the ICU, and they're going to need, your surgery, a necrosectomy. That dead tissue is going to need to be cut out, but that is supposed to wait. Let it congeal, then scoop it out later. If you try to go in too early, it's not going to help. So again, surgery not very useful. And let me clear the air on some things, because it's been back and forth for a while. We finally made a conclusion. If you have necrotizing pancreatitis, you do carbapenem antibiotics if. Carbapenem antibiotics if you have FNA proven infection. That is, you need a biopsy of the necrotic tissue that shows the growth of bug in order to give antibiotics. Now, you may clinically make the decision to give antibiotics before that happens, and it used to be based on the percentage of necrotizing tissue, all gone. Now it is only give a carbapenem if the FNA proves an infection, which means you do an FNA if you think they are infected. Otherwise, necrotizing pancreatitis has a poor prognosis, and if they live to see it, necrostectomy. That person who remains septic with fever and leukocytosis at 5 to 7 days might have an abscess. And an abscess of the pancreas is no different than any other abscess. You're going to give antibiotics, but you, the surgeon, are going to take them to surgery. And the incision and drainage is going to be the utility of the surgeon. That person with early satiety, weight loss, and abdominal pain might have a pseudocyst. Now, the decision to actually operate or drain it is more complicated than this, of course. What I want you to see is that it's size and time. It has more to do with the symptoms and chance of resolution, but chance of resolution is chalked up to size and time. If it has been around for less than 6 weeks and it is less than 6 centimeters, it is uncomplicated and you can watch and wait. Get a CT scan at the end of 6 weeks, see if it's resolving. Watch and wait. But if it is greater than 6 weeks or greater than 6 centimeters, it's complicated. The chances that it might get infected or necrose are too high, and so it needs to be drained. How you drain it doesn't matter. Whether it's the cyst to the stomach, the cyst to the jejunum, or the cyst to the outside world, so long as it gets drained, that's all you need to worry about. So surgery doesn't really have a whole big role in pancreatitis. Necrostectomy, drainage, and incision and drainage for the complications of pancreatitis. And even though it doesn't have anything to do with surgery, let's talk about it. Chronic pancreatitis. Simply put, if you have chronic pancreatitis, you do not operate. No surgery for chronic pancreatitis. Yes, they're going to have chronic debilitating pain that requires pain medications. Yes, they might need insulin and enzymes because both the endocrine and exocrine function isn't working. But removing the pancreas only makes it worse and does not decrease the pain. Do not operate for chronic pancreatitis. The takeaway here is surgery is not for pancreatitis. Leave that to the medicine folks. But where surgery might happen is in the complications, which can be identified on a CT scan that you don't need when they walk in the door, but you need it later on to find out the complications. That's pancreatitis.